Next, we have seizures or status epilepticus. So status epilepticus is defined as either continuous seizures activity for 5 minutes or more, or 2 or more seizures that occur without full return of consciousness between them. Status epilepticus is a true medical emergency. So, some things you want to gather. How many seizures has the patient had? Was there a lucid interval between the seizures? A history of seizures or epilepsy? Do they have a medication list that includes anticonvulsants? Are they compliant with their medications? What did their seizure look like? Was the seizure preceded by any trauma? Check for the scene for any signs of drug overdoses, pill bottles, alcohol intoxication or withdrawal, drug use, fever, such as a febrile seizure in a child, head trauma, the duration, and the description of the seizure, it's often inaccurate, and a history of diabetes known as hypoglycemia. For symptoms, you're looking for a headache, neurological changes, seizure activity, and confusion. For their physical examination, you're looking for an altered mental status, eyes deviating or twitching, tonic or clonic movements, tongue biting, incontinence, either urine or fecal, and look for joint dislocations via the shoulder. For basic life support, you want to watch out for airway, breathing, and circulation. You can use an NPA and suction as necessary. However, do not place anything between the teeth. It can break off. So don't use an OPA in this scenario. You can apply oxygen via a non-rebreather if the patient has a decreased level of consciousness, and assist ventilations with the BVM as needed. Protect the patient from physical harm and embarrassment. Apply spinal motion restriction if there's any suspected head or neck trauma. Check a blood glucose level. Watch out for hypoglycemia as the cause of the seizure, and administer 15 to 30 grams or 10 grams to a child via the mouth if the patient has an intact gag reflex and the blood glucose level is less than 70. All seizing patients need a blood glucose check. This is huge. If you don't do this and you go to the ER, you're getting ripped to shreds. You want to cool a febrile pediatric patient by removing clothing, applying tepid water, and fanning. You can apply a pulse oximetry device, keep oxygen saturation greater than 94%. And for ALS, you want to control the airway. Often intubation isn't needed. Use a BVM initially and only intubate patients who remain with an inadequate ventilatory effort after using a BVM. Establish IV access. All patients with a recent seizure need IV access if it can be obtained. And establish IV with a saline lock. Monitor their 12 lead. Refer to particular cardiac dysrhythmia protocols as needed. Obtain a 12 lead EKG if available, if the patient has stopped seizing and the time allows for it. If the patient is having active or persistent seizures, administer diazepam Valium 5 to 10 milligrams or 0.2 milligrams per child for the child IV, or midazolam Versed 2 milligrams to 5 milligrams at 0.1 milligram per kilogram, either intravenously, intramuscularly, or a mucosal atomizer device. So pay attention to the difference here on how we administer diazepam with just an IV, or if we're going to go with Versed, we're going to use these different routes. Up to 20 milligrams or 10 milligrams of a child of total diazepam can be administered over time, or 10 milligrams or 5 milligrams to a child is the max use of midazolam or Versed without online medical control. Medical control must be contacted for further guidance if a patient is still seizing after 20 milligrams or 10 milligrams of the total diazepam, or 10 milligrams or 5 milligrams of total midazolam has been administered. In a child in whom IV or IO access is indicated cannot be established, then diazepam 0.5 milligrams per kilogram for a child may be administered rectally. You may repeat rectal diazepam doses at 2.5 milligrams every 5 to 10 minutes, up to a total dose of 10 milligrams for a child. Midazolam or Versed, 5 milligrams or 0.1 milligram per kilogram for a child, intramuscularly or via a mucosal atomizer device, may be administered for seizure treatment before an IV attempt if clinically indicated. The patient should be on cardiac monitor and pulse oximetry if either diazepam or midazolam is administered. If a patient is hypoglycemic, their blood sugar is less than 70, we want to administer 25 grams of D10 via IV, or 0.5 grams per kilogram for pediatric patients, or glucagon, paramedic only, at 1 milligram or 0.5 milligrams for a child intramuscularly if unable to obtain IV access. If the patient is febrile with a temperature greater than 101 degrees Fahrenheit, and is conscious with an intact gag reflex, consider the administration of acetaminophen at 1,000 milligrams PO if they're greater or than or equal to 70 kilograms, or 500 milligrams PO if they're 50 to 70 kilograms, and 15 milligrams per kilograms for a pediatric patient. Reassess the vital signs frequently. Note, do not administer Valium by the intramuscular route due to poor and erratic absorption. Versed is more water soluble and it's more well absorbed, basically, and may be used intramuscularly or via a mucosal atomizer device in an adult. For a pulse oximetry and cardiac monitoring, it's mandatory for all of these patients who receive diazepam or midazolam. It is best to administer diazepam or midazolam slowly to prevent hypotension or respiratory depression. Suspect a cardiac etiology in patients greater than 50 years old with seizure activity. It's often the first sign of cerebral hypoxia from cardiac arrest due to severe hypoperfusion of the brain. Febrile seizures are uncommon in patients greater than 6 years old. All first-time new onset seizure patients should be transported to the ER for evaluation and workup. Rectal diazepam may take up to 5 minutes to take effect. Always check a blood glucose level in a seizure patient and treat hypoglycemia as needed. Remember that not all seizures are tonic, clonic, or a grand mal in nature. Often it is necessary to look closely for subtle signs of a focal seizure. Patients that are still conscious and talking to you or following commands are not having a true seizure. Adjust your treatment plan accordingly for these patients and contact medical control for guidance as needed in these pseudo-seizure patients. Always consider eclampsia in the seizing of a third trimester patient or within 1 month postpartum. Mag sulfate 4 grams total can be administered with a slow IV push over 2 minutes, and it's a treatment of choice in these patients. Be very careful with how your mag sulfate is carried though. Ours is at 50%, so you need to reduce it to a 10% concentration before you administer it. Paramedic personnel may utilize the mucosal atomizer device as an alternative drug delivery adjunct for patients without IV or IO access who require the urgent administration of midazolam or Versed. See protocol page 152. For shortness of breath in a non-traumatic scenario, this protocol will cover shortness of breath including congestive heart failure, pulmonary edema, COPD, pulmonary embolus, asthma, stridor, and croup. There are many causes of shortness of breath, and it is often difficult to diagnose the exact cause of shortness of breath in the field. This protocol will give you a basis on how to manage any shortness of breath patient regardless of the cause. Often the patient's history can aid your assessment and treatment plan. You want to watch out for a history of CHF, a reactive airway disease like COPD, fever, pneumonia, bronchitis. You want to watch out for chemical inhalation, tobacco use at home, coronary artery disease, a history of leg swelling, because we're thinking about an embolus, or recent pelvic or leg surgery with prolonged bed rest. Watch out for spontaneous pneumothoraxes, possible foreign body obstructions, hives, anxiety, and compliance to medications. Make sure that they are. You want to watch out for symptoms of shortness of breath, chest pain, wheezing, sweating, peripheral edema, cough, fevers, hives, the inability to lie flat, dyspnea without exertion or with exertion. Now, for BLS or basic life support, we want to make sure we monitor their ABCs or their airway breathing circulation, apply an oxygen device. Any patient with significant shortness of breath should be on high flow O2 via a non-rebreather unless primary hyperventilation is suspected. Patients with very mild shortness of breath can be treated with oxygen via a nasal cannula device at 2 to 4 liters per minute. Place a patient in a position of comfort, usually sitting up if no trauma is suspected. Assist ventilations with the BVM as needed. Consider BVM if the adult patient has a respiratory rate less than 10 per minute or greater than 30 per minute. Obtain vital signs with the patient. If the patient with a congestive heart failure exacerbation has a blood pressure reading, if it's elevated, that can potentially be normal. If you want to make sure you establish a pulse oximetry device on them, if a patient is wheezing, administer albuterol 5 milligrams or 2.5 milligrams to a child via nebulizer or a metered dose inhaler at 2 to 4 puffs. They may repeat it every 5 to 10 minutes as needed. If a patient has a suspected allergy component, see the allergic reaction or anaphylaxis protocol on page 23. For advanced life support, you want to intubate the patient as necessary, such as if they have like a decreased level of consciousness, lethargy, unable to follow commands, absent gag reflex, and increased respiratory distress, etc. You want to monitor an EKG rhythm. Frequently, shortness of breath patients will have a ventricular ectopy or AFib. If a dysrhythmia is encountered, refer to the particular protocol. Obtain a 12 lead if time allows, and you also want to consider putting the patient in a position of comfort as close to supine as possible. Establish IV access. You would want to set up a saline lock. Administer IV fluids if the patient is hypotensive. However, if there's evidence of fluid overload or lung auscultations reveal crackles, do not administer IV fluids to further avoid fluid overload. If a patient is wheezing, administer albuterol at 5 milligrams or 2.5 milligrams if it's a child via a nebulizer. You may repeat this every 5 to 10 minutes up to 15 milligrams, or for a pediatric patient, 7.5 milligrams in total. If the patient has severe wheezing, you may administer albuterol 15 milligrams or 7.5 milligrams on a continuous albuterol nebulizer treatment. If an allergic reaction is suspected, administer diphenhydramine or Benadryl at 25 to 50 milligrams or 0.75 milligrams per kilogram for a child via IV or IM. Consider epinephrine 1 to 1,000 intramuscularly at 0.3 milligrams or 0.01 milligrams per kilogram for a child for very poor air movement and cyanosis. Be very cautious administering intramuscular epinephrine to patients who are greater than 50 years old, are pregnant, or have a history of coronary artery disease. Be very cautious giving epinephrine intramuscularly to a hypoxic patient, as it will increase their oxygen demand on an already irritable heart. See the allergic reaction and anaphylaxis protocol on page 23. If a patient is wheezing significantly and has a history of asthma or a suspected allergic component to the patient's wheezing, administer methylprednisone or solumedrol at 125 milligrams or 2 milligrams per kilogram to a child via IV or IM over 1 minute. It is very important to let the receiving emergency department staff know that methylprednisolone has been administered in the field, so that it will not be repeated in the emergency department. If significant wheezing and respiratory distress persist, consider using CPAP therapy, which we'll see in protocols on the page 133. If bilateral crackles or rales are present, and the patient has pedal edema or JVD with suspected CHF, pulmonary edema diagnosis, administer furosemide or Lasix at 40 milligrams or 1 milligram per kilogram for a child IV if the patient is not currently on furosemide. If the patient is already on furosemide, double the patient's single dose up to 100 milligrams, or for a pediatric patient, 3 milligrams per kilogram for a child IV. Do not administer furosemide to a suspected patient that may be having pneumonia, they have a fever, or a productive cough. If a patient has suspected acute CHF exacerbation, such as crackles, pedal edema, JVD, and hypotension, administer nitroglycerin 0.4 milligrams sublingually or spray every 5 minutes up to 3 total doses, even if the patient has taken their own nitroglycerin prior to EMS arrival. Keep systolic blood pressures at 100 millimeters per mercury or greater. Monitor the blood pressure very closely. Do not administer nitroglycerin to a patient with suspected pneumonia with a fever or productive cough. In addition to nitroglycerin, morphine sulfate can be administered at 2 milligrams to 10 milligrams with a slow IV push, or fentanyl at 50 to 100 micrograms for significant pulmonary edema to reduce preload and afterload. If significant respiratory distress is present, consider using CPAP therapy, which is on page 133. If a decreased respiratory rate is thought to be due to an overdose or over-medication of opioids, administer Narcan or naloxone at 2 milligrams or 1 milligram for a child via an IV intramuscularly or via a MAD device. If a patient is febrile with a temperature greater than 101 degrees Fahrenheit and is conscious with an intact gag reflex, consider the administration of acetaminophen 1000 milligrams PO, greater than or equal to 70 kilograms, or 500 milligrams PO, via if they are 50 to 70 kilograms, or 15 milligrams per kilograms for a child. Consider norepinephrine drips set at 8 micrograms per minute to 12 micrograms per minute via IV if the adult patient is suspected of being in cardiogenic shock, a systolic blood pressure less than 100 millimeters per mercury, with pulmonary edema, and unresponsive to 500 milliliters of IV fluid. Try and maintain a blood pressure greater than 100, at least for the systolic reading. So now some notes. Make sure that if nitroglycerin is administered, that the patient did not take any erectile dysfunction medications like Viagra, Levitra, or Cialis in the last 24 hours. Remember, epinephrine is only indicated for non-pregnant patients less than 50 years old without a history of coronary artery disease and are in severe respiratory distress. uh, hypotension without relief from albuterol, and thought to have an allergic component to their wheezing. Do not withhold oxygen to a COPD patient. They are having severe shortness of breath and arrhythmias. Often high flow O2 in the field can help them. If there is a prolonged transport time, look closely for hypoventilation due to abolishing the COPD's patient's hypoxic drive and assist with the BVM as necessary. Just because a patient has a history of CHF and has pedal edema on exam does not mean that they all need furosemide. Only administer furosemide if the patient is having shortness of breath with evidence of fluid overload or crackles. Do not have a suspected hyperventilation patient breathe into a paper bag or a non-rebreather mask without oxygen. Instead, use verbal coaching and reassurance to slow the respiratory rate. The patient may be, in fact, experiencing diabetic ketoacidosis and are having Kussmaul breathings to blow off carbon dioxide. By having the patient breathe into a paper bag, the carbon dioxide can be dangerously high and could potentially be fatal. Often pneumonia and congestive heart failure will both have crackles or rales on auscultation of the chest. To help distinguish the CHF patients, they may have pedal edema, JVD, and an acute onset, while pneumonia patients will often have fever, cough, nasal congestion, chest wall pain, and a more gradual onset. Do not administer furosemide or Lasix or nitroglycerin to a patient with suspected pneumonia. Remember that the amount of wheezing auscultated may worsen after the albuterol treatment. In fact, the patient may be improving due to an opening of the bronchioles, which causes better airflow and louder wheezing. Consider pulmonary embolus if a patient has a history of tobacco use, prolonged travel, or bed rest, lower extremity immobilization, recent pelvic surgery, a history of deep vein thrombosis, a DVT, or oral contraceptive use. For a stroke or a CVA, this protocol applies to patients with an altered mental status, slurred speech, or focal weakness without any obvious other etiology. In an ischemic stroke, a clot forms, known as a thrombotic, in a blood vessel in the brain or travels, known as an embolic, from a distant blood vessel, e.g., a carotid artery. An embolic stroke are the most common in the middle cerebral artery, and ischemic strokes account for 85% of all strokes and are usually secondary to atherosclerosis. A hemorrhagic stroke occurs from a rupture of a cerebral vessel, with bleeding occurring into brain tissue, intracerebral hemorrhage or ICH, or areas surrounding the brain, a subarachnoid hemorrhage, SAH. Hemorrhagic strokes are usually due to hypertension, but may also be due to an aneurysm or arteriovenous malformation, AVM. An intracerebral hemorrhage, ICH, is usually the result of severe hypertension with bleeding into the brain tissue. A subarachnoid hemorrhage is bleeding into the subarachnoid space, the cerebrospinal fluid space, which is usually the result of the rupture of a congenital aneurysm, or after head trauma. A transient ischemic stroke, or a mini stroke, a TIA, is defined as a reversible neurological event. The symptoms will completely resolve within 24 hours. An acute stroke is described in a patient that has symptoms which began less than 6 hours ago. This is the time from when the patient was last seen normal. For the history, you want to check if they had previous strokes, old neurological deficits, or hypertension, diabetes, known brain aneurysms, brain cancer. When did the symptoms begin? When was the sudden onset? For symptoms, you're looking for a headache, neurological deficits such as a focal weakness, slurred speech, facial drooping, an altered mental status like a coma, stupor, confusion, seizures, or delirium, incoordination, paralysis, numbness, ataxia, which is poor balance, difficulty swallowing, vertigo, vomiting, and changes in vision. For physical examination, we're looking for an altered mental status, slurred speech, or the inability to speak, facial drooping, focal neurological weaknesses known as paresis or numbness, ataxia, cranial nerve abnormalities. For basic life support, we want to get ABCs on them, airway, breathing, circulation. We want to establish the last time the patient was seen normal. And this is so big. If you don't do this, you're in a lot of trouble when you get to the ER for the patient. This will be the presumed time of onset of the stroke. Apply oxygen, use an NPA or an LPA airway device, and a BVM as needed, either if the respiratory rate or the tidal volume is inadequate. Perform spinal motion restriction if the possibility of a spinal injury exists. Obtain vital signs. Examine the patient closely for any signs of head trauma. Check a blood glucose level. Administer oral glucose 15 to 30 grams by mouth if the blood glucose is less than 70 units and the patient has an intact gag reflex. Consider other causes of an altered mental status. See page 25. Elevate the head of the bed to 30 degrees if no trauma is suspected. Apply a pulse oximetry device and monitor oxygen saturation levels. For ALS, intubate as necessary to protect or maintain the patient's airway. Monitor a 12 lead. Establish IV access with a saline lock. If a patient's blood glucose level is less than 70, administer D10 at 25 grams. Do not administer D10 unless the blood glucose level is low, as the hypertonic blood glucose or glucose load can be harmful to an already ischemic brain tissue. Basically, we don't want to cause necrosis in brain tissue, so be careful. If a patient is seizing, administer diazepam Valium at 5 to 10 milligrams with a slow IV push. If the symptomatic stroke patient either has a systolic BP greater than 220 units and or a diastolic at greater than 110 units, administer labetalol, also known as Normandin, at 10 to 20 milligrams with a slow IV push over 2 minutes. Monitor their blood pressure closely and make sure you inform the ED staff or the emergency department staff that labetalol was administered to the patient in the field. If a patient is vomiting severely, having repetitive vomiting or retching, administer andesartan or Zofran at 4 milligrams IV or intramuscularly, but that's for an adult. Significant vomiting will increase the intracranial pressure. Perform a Cincinnati stroke for all suspected stroke patients. If at least one of the 3 exam findings are abnormal and the time of symptoms, the time lasting normal, is less than 3 hours, then all acute strokes should be transported to an accredited stroke center for possible thrombolytic or TPA administration. The goal is symptom onset to thrombolytic TPA time less than 3 hours. However, some neurologists are now extending the window out to 4.5 hours. See the Cincinnati Pre-Hospital Stroke Scale exam on page 132. In addition, perform the EMS VAN acute stroke screening tool seen on page 191. Note, strokes are the 3rd leading cause of death in the United States. Like an acute myocardial infarction, immediate recognition of a stroke condition and initiation of treatment can reduce the amount of disability and death. TPA or thrombolytics may be administered at the stroke center hospital if the patient has an ischemic stroke of less than 4.5 hours of duration, clearly defined by the time of the onset of symptoms, no history of intracranial hemorrhage, neoplasm, AV malformation, no recent or less than 3 months of a major surgery or serious head trauma, and no active internal bleeding. The goal of the treatment for the selected TPA patient is 60 minutes from the door, arrival in the emergency department, to thrombolytic administration. The onset of symptoms is defined as the last time the patient was witnessed to be symptom-free. Stroke patients are at an increased risk of vomiting, aspiration, and loss of airway control. Do not lower the blood pressure too low. Maintain the systolic BP between 160 to 180 units to assist with adequate blood flow to the brain. A higher than normal blood pressure is needed to help perfuse in and around this area of cerebral ischemia or hemorrhage. Never lower the blood pressure too low. Current stroke centers include Christus Spawn Shoreline, this is only for Corpus, Bay Area Medical Center, and Doctors Regional Hospital. Supraventricular tachycardia, or STV, either being stable or unstable. So, to introduce this topic, the stable SVT patient may have palpitations, dizziness, or lightheadedness. However, this is very important, the unstable SVT patient may also, including these, have chest pain, shortness of breath, hypotension, or an altered mental status. For the patient's history, you want to check to see if they have any coronary artery disease, hypoxia, heavy caffeine use, smoking, thyroid disorders, congenital heart diseases, and if they're on any antidysrhythmic medications. You want to check for symptoms like palpitations or the racing heart, shortness of breath, lightheadedness, dizziness, chest pain, hypotension, an altered mental status, and a cough. For a BLS, all you're really going to do is check for ABCs, apply oxygen, obtain vital signs. Their pulse will normally be between 150 to 250 beats per minute, and pulse oximetry. For ALS or advanced life support, control the airway as needed, monitor an EKG rhythm, and obtain rhythm strips for later emergency department review. The EKG will show a ventricular rate between 150 to 250 beats per minute with a QRS less than 0.12 seconds. Usually there's no P wave, and it must be differentiated from sinus tachycardia. Obtain a 12-lead EKG prior to treating the patient if available, if a patient is stable and time allows. This will be very helpful to the treating emergency physician and the cardiologist. Establish an IV access. You want to try to go for a large bore IV at an AC region if possible. Start IV fluids at normal saline at 60 mLs per hour if the patient is stable. And if the patient is unstable, you want to give them an IV bolus between 250 to 1,000 milliliters or 20 milliliters per kilogram for a child. Consider vagal maneuvers or Valsalva maneuvers if the patient is cooperative. Vagal maneuvers consist of having the patient bear down against a closed glottis or glottis. Do not perform a carotid sinus massage due to the risk of embolizing a carotid artery plaque. If a patient is stable, administer adenosine or adenocard at 6 milligrams to 12 milligrams or 0.1 milligram per kilogram to 0.2 milligram per kilogram for a pediatric patient with a rapid IV push followed immediately by 10 to 20 milliliters of a normal saline flush. If there is no response to the initial adenosine, after 2 minutes, the patient remains in SVT, the adenosine may be repeated at 12 milligrams at a rapid IV push, followed immediately by a 10 to 20 milliliter flush, and a total of 30 milligrams or 0.5 milligrams per kilogram for a pediatric patient. IV adenosine may be administered in total. It is very important to warn the patient before giving them adenosine that they will experience transient flushing, nausea, head rush, chest tightness shortly after the adenosine is administered. If the patient is unstable, they have significant chest pain, shortness of breath, hypotension, and altered mental status, consider adenosine 12 milligrams or 0.2 milligrams per kilogram for a child with a rapid IV push followed immediately by a 10 to 20 milliliter flush, or go directly to synchronized, make sure it's synchronized, cardioversion. Perform synchronized cardioversion at 120 joules or 1 joule per kilogram for a child. If still in SVT after the initial synchronized cardioversion, increase the energy to 200 joules or 2 joules per kilogram. If still in SVT, consider adenosine 12 milligrams or 0.2 milligram per kilogram for a child with a rapid IV push, then repeat synchronized cardioversion at 200 joules or 2 joules per kilogram for a child. Consider midazolam or Versed at 1 to 5 milligrams with a slow IV IO or via a mucosal atomizer device prior to synchronized cardioversion in an awake adult patient. Have a BVM and intubation equipment readily available prior to giving midazolam. For some notes, given the very short duration of adenosine, approximately 10 seconds, it must be administered in a proximal IV site, either the AC or the external jugular, and give the flush immediately after administering the adenosine to make sure the adenosine reaches the heart quickly. Adenosine will often not work on patients taking theophylline, aminophylline, or a high-dose caffeine due to the antagonist effects of methylhexanines. Synchronized cardioversion should rarely be needed if the patient's with a heart rate less than 150 beats per minute. It's high likelihood that it's not SVT. SVT is the most common dysrhythmia seen in pediatric age groups. If the heart rate is greater than 220 beats per minute for an infant or 200 greater beats per minute in a child, then it is usually SVT. For suspected cocaine or amphetamine-induced SVT, administer diazepam or Valium at 5 milligrams to 10 milligrams with a slow IV push, or alternatively, administer midazolam or Versed at 1 to 5 milligrams with a slow IV push intramuscularly or via a mucosal atomizer device. A good rule of thumb for the maximum sinus tachycardia rate in a patient is 220 beats per minute minus the patient's age. This works for patients up to 50 years old or so, and if the patient has a heart rate greater than this, it is usually not sinus in origin. For syncope, syncope is a brief loss of consciousness, also referred to as fainting. For history, you want to check out the patient's cardiac history. They've had a stroke, seizure, a history of syncope, occult blood loss, either via a GI or ectopic, female's last menstrual cycle, vaginal bleeding, fluid loss such as vomiting, diarrhea, past medical history, medications. What was the patient doing when they felt like they were going to faint? Symptoms: did they have loss of consciousness with recovery, lightheadedness, dizziness, palpitations? For BLS, you want to make sure you're checking out their ABCs, get a SpO2 on them, apply oxygen as needed, check their vital signs, check their blood glucose levels, and assess for any signs and support of trauma. Spinal motion restriction should be used if there is any indication of head trauma, neck pain, or back pain during syncope. For ALS or advanced life support, monitor a 12-lead and record a rhythm strip. Administer D10 at 25 grams IV if the patient is hypoglycemic. If unable to obtain an IV on these hypoglycemic patients, administer glucagon, which is paramedic only, at 1 milligram or 0.5 milligrams for a pediatric patient intramuscularly. Establish IV access of normal saline at 60 mLs per hour or a saline lock if the patient is not hypotensive. If they are, though, you can administer 250 to 1,000 milliliters or 20 milliliters per kilogram for a pediatric patient, and maintain a systolic blood pressure greater than 100 millimeters per mercury. Use IV fluids with caution in patients with crackles field on lung auscultation. If any relevant signs and symptoms are found, refer to the appropriate protocol. Note, more than 25% of all geriatrics patients greater than 65 years old have syncope related to cardiac dysrhythmias, so make sure you get that 12 lead. For toxicological emergencies or drug overdosing, poisonings, a patient may have a history of suspected, witness, or alleged ingestion, inhalation, or exposure. The management of this poison patient depends on 3 principles. Decontamination. We want to limit further absorption and minimize the extent of the toxicity. Supportive care. Limit the effects of the poisoning on the primary organ systems that are at risk. Definitive care. We want to limit the severity of duration of the toxicity through the use of antidotes that enhance elimination or reverse the effects of the toxin itself. For history, we want to use family or bystanders as needed, or the patient if they can answer. You want to see the type of medications or drugs they're exposed to and the time of the ingestion, which is very important. The amount taken. Has the patient vomited or coughed since ingestion? The reasoning for poison, was it accidental or intentional? That's a huge one. A history of attempts, current medications, allergies, history of drug abuse. For symptoms, check if they're agitated, if they have an altered mental status, pupillary changes, skin changes, abnormal vital signs, an unusual odor on their breath, respiratory distress, nausea or vomiting, seizures, and muscle cramps. For physical examinations, you want to check out for an altered mental status, pupillary changes, skin changes, abnormal vital signs, unusual odor on their breath, venous tract marks, gag reflexes, secretions, and an oral mucosal burn. You want to look out for toxidromes, such as the cholinergics. You can use the SLUDGE acronym to help you with salivation, lacrimation, urination, diarrhea, GI cramping, and emesis. For cholinergic exposures, including organophosphates. Also, they may have muscle fasciculations, meiosis, constricted pupils, wheezing, bradycardia, or seizures. For opioids, you want to watch out for the triad of meiosis, constricted pupils, decreased respiratory rate, and a decreased level of consciousness. For anticholinergics, we want to watch out for confusion, warm and dry skin, blurry vision, such as mydriasis, dilated pupils, urinary retention, and dry mouth. It can be remembered as mad as a hatter, red as a beet, blind as a bat, and dry as a bone. For tricyclic antidepressants or TCAs, we want to watch out for an altered mental status, seizures, dysrhythmias, and hypotension. For basic life support, we want to make sure the scene is safe. Do not contaminate yourself while treating the patient. Ensure a protective environment for yourself and the patient. Park the ambulance upwind if applicable, and use appropriate PPE. Check out their ABCs, obtain vital signs, apply oxygen via a non-rebreather mask if they have an altered mental status, or use a BVM if needed. If evidence of contamination exists, immediately decontaminate, remove the patient from the contaminated area, remove the patient's clothing, wash the patient's skins if indicated, flush the patient's eyes or mucous membranes if needed. Attempt to locate the nature of exposure or ingestion, collect pill bottles if present, and bring them to the hospital with the patient. Bring chemical or cleaner containers if possible. They can be transported in a safe manner. If not, carefully record the name and the ingredients off the label. Attempt to obtain the time of ingestion from family or bystanders. Check a blood sugar level and treat as necessary. Some poisonings are associated with a sudden profound hypoglycemia, such as aspirin, opioids, and alcohol. Have portable suction readily available, as emesis is common after a poisoning. Watch out for pulse oximetry. Remember that carbon monoxide poisoning will register a false elevated pulse ox reading. Treat the patient, not the pulse oximetry reading. You want to intubate the patient if necessary for an ALS provider. Monitor a 12 lead if possible. Many overdoses will affect the heart, such as digoxin, beta blockers, calcium channel blockers, tricyclic antidepressants, amphetamines, etc. Refer to particular dysrhythmia protocols as indicated. Establish an IV access. Administer saline if the patient's blood pressure is less than 100 millimeters per mercury, but watch out for crackles. Administer D10 or dextrose at 25 grams via IV if the blood sugar is less than 70 units. Also 0.5 grams per kilogram for a pediatric patient. Administer naloxone or Narcan at 2 milligrams or 1 milligram for a child, IV, IM, or MAD device. If suspected opioid use and respiratory depression, a decreased gag reflex exists. It may be prudent to administer Narcan or naloxone slowly and titrate the effect to avoid appropriate opioid withdrawal. Remember, the goal is only to normalize the respiratory rate and protect the gag response. If a tricyclic antidepressant TCA overdose is suspected, administer sodium bicarbonate 1 amp at 50 mg per IV, and a tricyclic antidepressant overdose TCA overdose may include a widened QRS complex on the heart monitor and a heart rate greater than 120 beats per minute, hypotension, or seizures. Note that the newer antidepressants, Zoloft, Prozac, Effexor, Pristiq, Celexa, and Paxil, are not TCAs, and rather they are selective serotonin reuptake inhibitors, or SSRIs. If an organophosphate poisoning is suspected and the patient is symptomatic, use the SLUDGE syndrome, or SLUDGE acronym, then administer atropine at 2 milligrams or 0.04 milligrams per kilogram for a pediatric patient via IV. Contact medical control for possible repeat administration of atropine at 2 milligrams or 0.04 milligrams per kilogram for a child every 5 minutes if possibility of significant organophosphate exposure is realized. Administer atropine until signs of atropinization occur, such as the mydriasis, tachycardia, the drying of the secretions on skin. If a calcium channel blocker overdose is suspected, bradycardia and EKG conduction delays, hypotension, lethargy, nausea, or vomiting may have occurred. Administer IV fluid boluses as above. If symptomatic bradycardia is present, administer atropine at 1 milligram via IV, and you may repeat the atropine dose every 5 minutes as needed until 3 milligrams is administered in total. Contact medical control for possible calcium gluconate order at 1 gram per IV over 5 minutes if the patient remains in refractory to the IV fluid bolus and atropine. Contact medical control for possible glucagon, 3 milligrams to 5 milligrams via IV, and order if the patient remains asymptomatic after IV fluids and atropine. For a beta blocker overdose, it's suspected if they have bradycardia or hypotension. Administer IV fluid boluses as above. If the symptomatic bradycardia is present, administer atropine at 1 milligram via IV. They may repeat the atropine 1 milligram via IV every 5 minutes as needed, and the patient remains bradycardic and hypotensive until 3 milligrams of IV has been administered in total. Contact medical control for possible glucagon at 2 milligrams IV and order if the patient remains asymptomatic after IV fluids and atropine use. Contact medical control as needed for guidance in all complex overdoses and poisonings and exposures. Notes: do not rely on the patient's history of ingestion for a patient that's trying to hurt themselves. Make sure that the patient is still not carrying other medications or weapons on their person. Actively, patients that want to hurt themselves cannot refuse transport. Involve law enforcement and medical control as needed. Contact poison control as needed. Victims of fire may have been exposed to toxic gases, especially carbon monoxide and cyanide. These patients may have associated burns, singed nasal hairs, or carbonaceous sputum. Always administer high flow O2 and intubate early if indicated. Signs of carboxyhemoglobinemia, what the heck, include flu-like symptoms, headache, nausea, or vomiting, weakness, altered mental status, dizziness, shortness of breath, and chest pain. Remember that cherry red skin is a very late finding. Do not administer syrup of ipecac in the pre-hospital setting. I don't know how to pronounce it. Contaminated patients should not be transported by aero medical transport given the potential risk to the safety of the aircraft crew. And EMS personnel may utilize a mucosal atomizer device as an alternative drug delivery adjunct for patients without IV or IO access, require the urgent administration of Narcan or naloxone and or midazolam or Versed. See page 152. And here we can see some names of some of these different types of medications. I'll just say their generic names. So we have For TCAs, we have amitriptyline. I don't know how to pronounce a lot of these actually, so we'll just say amitriptyline. Calcium channel blockers, we have things like amlodipine. And beta blockers, we have medications like the acebutolol. But if you want to look at this, you can pause it. Ventricular ectopy or ventricular tachycardia, stable with a pulse. Now the key term here is they're stable, they still have a pulse. VTAC is considered as 3 or more successive beats of premature ventricular contractions or PVCs with a QRS greater than 0.12 seconds. It is usually associated with a ventricular rate greater than 150 beats per minute. VTAC may or may not cause hemodynamic compromise. The protocol deals with stable VTAC patients with the pulse and without experiencing shortness of breath, severe chest pain, or an altered mental status. If the patient has no pulse or one of the above symptoms, refer to the unstable protocol for VTAC on page 80. There is bigeminy. It refers to PVCs that alternate with the normal sinus rhythm. Every other beat is a PVC. Or trigeminy refers to PVCs occurring with 2 normal sinus beats, and then they're on the 3rd beat with the PVC. Couplets refers to a pair of PVCs recurring together. For their history, usually they'll have a history of coronary artery disease. It may have a pacemaker or an automatic internal cardiac defibrillator or an AICD. And they may have symptoms or history of syncopal events, and they may be on antiarrhythmic medications. Their symptoms, they may have syncope, mild shortness of breath, mild chest pain, palpitations. If the patient has severe chest pain, severe shortness of breath, or an altered mental status, proceed to unstable VTAC protocols on page 80. For basic life support, all you're going to do is worry about their ABCs, apply oxygen. High flow O2 via non-rebreather mask is the primary treatment for ventricular ectopy or irritable ventricles. It may take 5 minutes for the oxygen to have full effect. Obtain vital signs and establish a pulse oximetry device on them. For ALS, you want to monitor an EKG rhythm and obtain a rhythm strip printout. You want to obtain a 12-lead EKG rhythm if available and if the time allows. Establish IV access with a normal saline lock and administer lidocaine at 1.5 milligram per kilogram IV if needed or if indicated. Lidocaine should be administered only if the patient is having greater than 10 PVCs per minute or heart rate greater than 80 beats per minute, multifocal PVCs or different types of PVCs, couplets, the ROT phenomenon, runs of VTAC, and it is not a 2nd or 3rd degree heart block. Discuss with medical control if the patient is very stable, as some physicians do not believe in administering lidocaine for PVCs. You may repeat lidocaine at 0.75 milligrams per kilogram IV, 1/2 the original dose every 5 minutes until the dysrhythmia resolves, or a total of 3 milligrams per kilogram of lidocaine may be administered. If needed, start a lidocaine drip at 1 to 4 milligrams per minute IV and monitor the patient closely for signs of lidocaine toxicity, an altered mental status, or seizures. If no response with lidocaine in an adult patient, administer mag sulfate at 2 grams IV over 2 minutes. If hyperkalemia may be present, ERSD or dialysis patient, administer sodium bicarb at 1 amp, which is 50 milliequivalents, IV, along with calcium gluconate at 1 gram IV, followed by sodium bicarbonate 1 amp, 50 milliequivalents, or IV. Be sure to thoroughly flush the IV tubing between the medications to avoid precipitation between calcium and bicarbonate. Ideally, these medications should be administered in 2 different IV ports to avoid precipitation. Now notes, look closely at the rhythm strip for evidence of pacemaker spikes. Patients with pacemakers normally have the wide QRS complex and usually do not need lidocaine. Prophylactic lidocaine is no longer indicated for routine use when PVCs are associated with an acute myocardial infarction. Never administer lidocaine to a wide complex rhythm that is less than 80 beats per minute. It may be an accelerated junctional rhythm, and giving lidocaine may result in immediate asystole. Mag sulfate is a drug of choice if the rhythm is torsades de pointes, polymorphic VTAC. If the patient is in torsades de pointes, administer mag sulfate 2 grams IV over 2 minutes before lidocaine. Some patients may have chronic bigeminy. If a patient is known to have chronic bigeminy or ventricular ectopy, lidocaine may be withheld after discussing with medical control. But make sure you discuss with medical control. I would call them for pretty much any of this, personally. For asystole patients, asystole is a flat line and a pulseless idioventricular or agonal rhythm. It's a wide complex, irregular heart rate at less than 60 beats per minute in 2 consecutive leads that would be considered in this protocol. Make sure the leads are connected properly and not accidentally disconnected. So basically, it's just a flat line that we're looking for here. So some history that we want to check is the history of the events leading up to the cardiac arrest, the sudden collapse, an electrical shock, past cardiac history, was a bystander on scene starting CPR, the time of the arrest that it started, you get my estimated downtime, congenital heart disease, ESRD, dialysis patients, hypothermia, and no valid state DNR form. We're looking for symptoms of unresponsiveness. So for BLS, we want to establish that the patient is unresponsive and without signs of obvious death, such as rigor mortis, independent lividity, etc. We want to check for breathing. If there's no breathing, begin bag valve ventilations, and we want to place an OPA in the patient. We want to immediately perform chest compressions at a heart or a rate of 100 to 120 beats per minute. We want to notify dispatch and the responding units that CPR is in progress if it's not already known. Apply AED. It will not shock in asystole, but it may shock fine ventricular fibrillation. So apply the AED. If the AED fires, be sure to tell the ALS crew how many shocks were delivered. Follow the AED prompts. Place an eye gel, an airway device, and ventilate with 100% oxygen. Check closely for evidence of trauma, gunshot wound, stab wound, etc. For ALS or advanced life support, apply the electrode pads and obtain a rhythm strip printout. If asystole, check in 2 leads. Continue CPR as needed, and establish an IV access, a large bore AC or external jugular one if possible, and administer IV fluids of normal saline that's wide open. Administer epinephrine 1 to 10,000 at 1 milligram or 0.01 milligram per kilogram IV push, and repeat with 1 milligrams of epinephrine at 1 to 10,000 or 0.01 milligram per kilogram IV every 5 minutes if the patient remains pulseless. Perform endotracheal intubation or place an eye gel airway device and ventilate with 100% O2, and confirm placement with an end-tidal CO2 detector and continuous waveform capnography. Attempt to pace with transthoracic external cardiac pacing if epinephrine has not worked. See transthoracic external cardiac pacing, appendix page 188. If external pacing does not produce mechanical capture, continue CPR and reattempt in 1 minute. Administer sodium bicarb at 1 amp or 50 milliequivalents IV if the patient had a prolonged downtime greater than 20 minutes of CPR. If the patient is a dialysis patient, this one is huge. Possible hyperkalemia is present, and administer 1 gram of IV calcium gluconate followed by sodium bicarbonate 1 amp at 50 milliequivalents IV. If you don't do this, the hospital staff's going to beat you up. Make sure you do it. Be sure to thoroughly flush the IV tubing between medications to avoid precipitation between the calcium and bicarbonate. Ideally, these medications should be administered in 2 different IVs or IO and separate IV to avoid precipitation. If patients develop a return of spontaneous circulation, obtain vital signs or blood pressure monitor it closely, and refer to the post-resuscitation management protocol, page 83. If the patient remains in asystole after the patient is intubated, IV or IO access is obtained, and they have 2 rounds of epinephrine with CPR, consider termination of the resuscitation efforts. Medical control must be contacted prior to terminating resuscitation. See termination of resuscitation, appendix page 138, and all patients in persistent or recurrent ventricular fibrillation, PEA, or those who have had a perfusing rhythm during the last 20 minutes of resuscitation should be transported to the hospital. In addition, all cardiac arrest patients in whom intubation or IV IO access has not been successfully completed should not be called in the field unless approved by online medical direction. Note: uninterrupted chest compressions are key to the success of this call. It takes 10 compressions to get good blood flow reestablished if chest compressions are interrupted or stopped. Administer medications in a cardiac arrest via an IV or an IO. The endotracheal route is no longer used to deliver these medications. We don't do that. Transthoracic external cardiac pacing should be used early in the arrest. The effectiveness of this modality decreases as the patient's downtime increases. Asystole is usually an ominous prognostic sign and signifies prolonged hypoperfusion or ischemia of the heart. At any time the patient's EKG rhythm changes, refer to the appropriate protocol. Always check the leads when monitoring. Shows asystole to make sure that there is a good connection and that no leads have peeled off. Always check for asystole in 2 leads. SIDS, or sudden infant death syndrome, occurs in infants between the ages of 1 month to 1 year old. Per the new 2010 AHA guidelines, atropine is not recommended for routine use in the management of asystole. Routine atropine in asystole is not recommended in the PALS guideline. In cardiac arrest patients, where the maintenance of continued chest compressions is of utmost importance, the placement of an iGel airway device as the initial airway device before an intubation attempt is an acceptable practice. If available, the rescue CPR system can be used on patients in cardiac arrest. See Rescue CPR protocol on page 181. For PEA, or pulseless electrical activity, the introduction is pulseless electrical activity, formerly known as electrical mechanical dissociation, refers to evidence of electrical activity on the monitor, but no palpable carotid pulse. Basically, we can see a rhythm on the monitor, but we can't feel for a pulse. PEA is used to describe only those rhythms that would be expected to produce a pulse, thus agonal rhythms are not included. The optimal treatment for PEA is to consider the underlying cause. They have hypovolemia. You want to administer IV fluid bolus at 1,000 milliliters or 20 milliliters per kilogram for a child. Hypoxia. You want to administer high flow 2 with a BVM or intubation. Acidosis or drug overdoses. You can do IV fluid bolus and consider sodium bicarb. Pericardial tamponade. You can do an IV fluid bolus and a rapid transport. Attention pneumothorax. Always consider if the cardiac arrest occurs after a severe asthma, COPD, chest trauma, or in any intubated patient. Perform a pleural decompression as outlined in page 175. A massive myocardial infarction. I'm going to do rapid transport. Hypoglycemia. Administer D10 at 25 grams IV if the blood sugar is less than 70 units. For a pulmonary embolus, consider high flow 2 and a rapid transport. For their history, you usually want to see a sudden collapse with a history of hypovolemia, a GI bleed, massive trauma, hypoxia, a drug overdose, hypoperfusion, pneumothorax, or a chest trauma. For their symptoms, they're going to be unresponsive. For BLS, you want to confirm absent respirations and an absent pulse, start CPR, and ventilate with a BVM at 100% oxygen. Place the patient on an AED, place an iGel, manage their airway, and ventilate with 100% oxygen. Apply pressure to any source of external hemorrhaging, and continue CPR. For ALS support, you want to monitor the EKG rhythm, obtain a rhythm strip printout, check for a carotid pulse. If no pulse is felt, perform CPR. Do not forget to continue CPR even though there's electrical activity on the cardiac monitor. Establish IV or IO access via the AC. You want to start IV fluids with normal saline at 1,000 milliliters via a bolus or 20 milliliters per kilogram for a child. Administer epinephrine 1 to 10,000 at 1 milligrams or 0.01 milligram per kilogram via IV. You may repeat the epinephrine administration at 1 to 10,000 or 1 milligram or 0.01 milligram per kilogram for a child IV every 5 minutes. Perform endotracheal intubation or place iGel airway devices and ventilate with 100% oxygen. Confirm placement with an end-tidal CO2 detector and perform continuous CO2 capnography. Establish a second IV line if able to and continue IV normal saline boluses. Consider bilateral needle thoracostomy, which is pleural decompression if possible, for the possibility of a tension pneumothorax that may exist. You can see page 175 for the pleural decompression appendix. You can administer sodium bicarbonate at 1 amp or 50 mg if the time of arrest is greater than 20 minutes. Administer calcium gluconate at 1 gram IV to adult patients if there's possibility of a hyperkalemic cardiac arrest. It could be renal failure or if they have dialysis. Followed up by sodium bicarbonate at 1 amp or 50 milliequivalents via IV. Be sure to thoroughly flush the IV tubing between medications to avoid precipitation between the calcium and bicarbonate. Ideally, these medications should be administered in 2 separate IVs or IOs and separate IV to avoid precipitation. Consider transthoracic external cardiac pacing, see page 188. If the patient develops a return of spontaneous circulation, see post-Ross protocols at page 83. Note: always check for the pulse in the carotid artery on an unconscious patient. It may be present in the carotid artery, but absent elsewhere. Always avoid any interruptions in chest compressions. It takes 10 compressions to get good blood flow reestablished if chest compressions are interrupted. Uninterrupted chest compressions are the key to success. High flow 2 via an intubation and IV fluids remains the hallmarks for treating PEA in the pre-hospital settings. Per the 2010 AHA guidelines, atropine is not recommended for routine use in management of PEA. Routine atropine in pulseless electrical activity is not recommended in the PALS guidelines. In cardiac arrest patients, where the maintenance of continued chest compressions is of utmost importance, the placement of an I-gel airway as the initial airway device before an intubation attempt is an acceptable practice. If available, the rescue CPR system can be used on patients in cardiac arrest. See the rescue CPR protocol on page 181. For VFib or VTach without a pulse, the introduction is unstable VTach refers to a patient who is pulseless, hypotensive, they have a new onset of an altered mental status, severe chest pain, or severe shortness of breath. Make sure that VFib patients are not experiencing an artifact. Always double check the lead connections before proceeding with defibrillation. Treatment priorities are effective, uninterrupted chest compressions at a rate of 100 to 120 per minute, prompt defibrillation, and then IV access and airway control. Do not stop chest compressions for placement of an endotracheal tube or to administer medications. The history is a sudden collapse or coronary artery disease. The symptoms is severe chest pain, shortness of breath, significant new onset of confusion, and unresponsiveness. Some physical examinations is going to be hypotensive or pulseless, and an altered mental status or a patient that's unconscious. For BLS or basic life support, you want to make sure that you open their airway as needed, check for breathing and for a carotid pulse. If you don't detect that, we're going to move forward to high flow 2 via a non-rebreather mask or a BVM as needed. Definitely we're going to go towards a BVM with an OPA or an NPA. We're going to start CPR if the patient is pulseless, notify dispatch and responding units that CPR is in progress. If cardiac arrest was not witnessed by EMS, perform 5 cycles of CPR prior to the first defibrillation. Apply AED if the patient is unresponsive and the AED is available. This is only for BLS. Refer to the AED appendix on page 118. Place an I-gel airway and ventilate at 100% O2. Obtain vital signs if they became present. Refer to the post-ROS management protocol on page 83. For advanced life support, you want to monitor an EKG rhythm, go ahead and get a 12 lead. And if in ventricular fibrillation or pulseless VTach, defibrillate at 200 joules or 2 joules per kilogram for a child. Repeat all subsequent shocks as a biphasic waveform at 200 joules or 4 joules per kilogram for a child. If prior shocks have been given by the AED, then start defibrillation at 200 joules or 2 joules per kilogram. Perform chest compressions immediately after defibrillation for 2 minutes before reassessing the patient. If the adult patient is in unstable VTach but still has a pulse or severe chest pain, severe shortness of breath, or a new onset of an altered mental status, perform synchronized cardioversion at 120 joules or 2 joules per kilogram for a child. Consider midazolam or Versed at 1 to 5 milligrams with a slow IV push, intramuscular or mucosal atomizer device on a conscious patient who is still awake prior to synchronized cardioversion. Establish an IV or IO access with a large bore AC. Start IV fluids with normal saline and leave it wide open at a 1,000 milliliter bag or 20 milliliters per kilogram for a child via IV. Perform an endotracheal intubation or place an I-gel if you're not able to, and ventilate at 100% O2. Confirm placement with an end-tidal CO2 detector and perform continuous CO2 capnography. Administer Epi 1 to 10,000 at 1 milligrams or 0.01 milligram per kilogram for a child IV push. Repeat 1 milligrams of epinephrine at 1 to 10,000 or 0.01 milligram per kilogram 1 to 10 for a child IV every 5 minutes. If the patient remains in VFib or pulseless VTach or Asystole. For defibrillation, you want to defib at 200 joules or 4 joules per kilogram. You want to administer lidocaine if the rhythm persists at 1.5 milligram per kilogram. If the patient is still in VFib or pulseless VTach, defibrillate again at 200 joules or 2 joules per kilogram for a child. If no response, repeat the lidocaine administration at 1/2 the initial dose every 5 minutes, up to 3 milligrams per kilogram in total to be administered. A lidocaine drip may be started at 1 milligram to 4 milligrams IV if the patient develops a return of spontaneous circulation, or known as ROSC. If the patient is still in VFib or pulseless VTach, defibrillate at 200 joules or 2 joules per kilogram. If it's possible that it's torsades de pointes in an adult patient, administer 10%, because remember we dilute this, of mag sulfate 2 grams IV over 2 minutes. Do not administer mag sulfate if the patient has known renal failure or is on dialysis. If glucose is less than 70 units, administer D10 at 25 grams IV or 0.5 grams per kilogram for a child. If a suspected opioid overdose is occurring, Administer naloxone or Narcan 2 milligrams or 1 milligram for the child via IV, intramuscularly, or a MAD device. If possible, hyperkalemia via a dialysis patient. Go ahead and administer calcium gluconate at 1 gram IV over 2 minutes, followed by sodium bicarbonate at 1 amp or 50 milliequivalents IV. Be sure to thoroughly flush the IV tubing between medications to avoid precipitation between the calcium and bicarbonate. Ideally, these medications should be administered in 2 different IVs or IO and separate IV to avoid precipitation. Administer sodium bicarbonate 1 ampule or 50 milliequivalents IV if hyperkalemia is suspected or if the patient has begun start cardiac arrest for 20 minutes or more now. If the patient returns or regains ROSC or return of spontaneous circulation, proceed to the post-ROSC management protocol on page 83. Note, for uninterrupted chest compressions, these are key to success. It takes 10 compressions to get good blood flow reestablished if the chest compressions are interrupted. Patients in VFib will not have a pulse. If patients convert to a different rhythm, but then reverts to VFib or Pulseless VTach, defibrillate at the most recent energy level. If the collapse is witnessed by an EMS personnel, a precordial thump, which should roughly give around 12 joules, may be administered immediately. Defibrillation should never be delayed, even for airway intervention. Rapid defibrillation is the treatment of choice for VFib. Make sure that the cardiac monitor defibrillation or defibrillator is taken from the ambulance on scene arrival for all patients who have the potential to be in cardiac arrest. Unconscious, chest pain, syncope, shortness of breath, you should always have your monitor at least. Having to return back to the ambulance for the defibrillator is always unacceptable. Perform defibrillation if VFib or Pulseless VTach and perform synchronized cardioversion if the patient has VTach with a pulse. If hypothermia is present and the patient does not respond to the initial defibrillation, continue CPR but do not perform further defibrillation attempts until the patient is warmed. The core temp has to be at least greater than 90 degrees. Refer to hypothermia section in the Environmental Emergencies protocol on page 39. Make sure that the administration of a medicine via the IV site is immediately flushed with IV fluid or a 10 milliliter saline flush to ensure the delivery of the medication into the central circulation. Patients converted to VFib or VTach from a perfusing rhythm with a heart rate greater than 80 beats per minute and an absence of second or third degree heart blocks should receive a lidocaine bolus of 1.5 milligram per kilograms IV if lidocaine was not previously administered. A lidocaine drip at 1 to 4 milligrams per minute should be started also. A patient in VFib should never be considered dead. Continue to work the code and transport the patient. VFib in a child is rare. If seen, suspect myocardial hypoxia or lack of oxygen to the heart, poisoning, or cardiomyopathy. Always consider hyperkalemia as a cause for cardiac arrest. In dialysis patients, administer sodium bicarbonate 1 amp at 50 mEq IV followed by calcium gluconate at 1 gram per IV to all cardiac arrest dialysis patient codes, or any other suspected patient of having hyperkalemia, i.e. a crush injury, potassium overdose, or chronic renal insufficiency. Be sure to follow through with a flush via the IV tubing between medications to avoid precipitation between calcium and bicarbonate. Ideally, these two should be used in different IVs or an IO and a separate IV to avoid precipitation. In cardiac arrest calls where the maintenance of the continued chest compressions is of utmost importance, the placement of an IGL airway as the initial airway device before an intubation attempt is an acceptable practice. If available, the rescue PCR system can be used on patients in cardiac arrest. See rescue CPR protocol on page 181. Post-resuscitation management. So to introduce this topic, this protocol applies to all patients with a return of spontaneous circulation, i.e. a palpable carotid pulse, after having undergone CPR for any non-perfusing rhythm, such as a cardiac arrest. The condition of post-arrest patients can fluctuate rapidly, and all of these patients require strict, close monitoring for any deterioration. For BLS, you want to maintain, You want to maintain the airway as appropriate, suction the patient as needed, place an NPA and high-flow O2 via a non-rebreather mask, and assist with ventilation with the BVM as needed. Most patients immediately post-ROSC will require ventilatory assistance. Do not hyperventilate a patient post-arrest, as this can lead to hypotension and a recurrence of cardiac arrest. Obtain vital signs every 5 minutes and frequently reevaluate the patient. For ALS, you want to have continuous and close cardiac monitoring as that's mandatory. You want to obtain a 12-lead EKG if it's available and the time allows. Establish IV access if it hasn't already been done, and administer an IV fluid normal saline bolus from 250 to 1,000 milliliters. And it's going to be 20 milliliters per kilogram for a child to keep their blood pressure greater than 100 millimeters per mercury. Intubate the patient if needed and it hasn't already been performed. If the patient is bradycardic with the pulse, refer to the bradycardic protocol on page 32. If an adult patient remains hypotensive despite an IV fluid bolus, start a norepinephrine drip from 8 to 12 micrograms per minute IV and titrate up as necessary to keep their blood pressure greater than 100 millimeters per mercury. Do not start the norepi drip till the patient has received an adequate IV fluid bolus. 500 milliliters is the minimum, or unless the patient is showing signs of pulmonary edema, such as cardiogenic shock, crackles on lung auscultation. If the patient was converted from VTAC or VFib and the patient has a heart rate greater than 80 beats per minute, administer lidocaine at 1.5 milligrams per kilogram IV if it hasn't already been administered. Start a lidocaine drip at 1 to 4 milligrams per minute if a patient had a significant ventricular ectopy. Do not administer lidocaine in the post-ROS patient with a heart rate less than 80 beats per minute or an idioventricular rhythm or a second or third degree heart block regardless of previous ventricular ectopy or lidocaine use. If it's appropriate for the patient, begin targeted temperature management protocols as outlined in protocols on the next page. Therapeutic hypothermia or targeted temperature management. To introduce this, there may be an improvement in the survival of cardiac arrest in patients who have a return of spontaneous circulation or ROSC and remain unconscious that are subsequently cooled or kept from having a fever. In addition, those patients that survive may have improved outcomes or better neurological functioning and independence. Early hypothermia pre-hospital delays the cascade of cellular death that occurs after cardiac arrest. Targeted temperature management, or TTM, is recommended by the American Heart Association for comatose cardiac arrest survivors with a sustained return of a pulse. Annaville Fire Department will use N-gel coolers, blah, 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 to keep 2 liters of 9% or 0.9% normal saline at 4 degrees Celsius. Some history you want to gather. Is the patient a non-traumatic cardiac arrest? If they are, including warm water arrest and asphyxiation with a return of spontaneous circulation within 30 minutes after cardiac arrest. Is their age greater than 16 years old? Is the patient pregnant? Is the patient unconscious with no purposeful reaction to pain? And is their systolic blood pressure greater than 90 millimeters per mercury? So you don't want them to be pregnant. Exclusion criteria: if they have active bleeding or coagulopathy. Do they have purposeful response to verbal commands or noxious stimuli prior to starting the targeted temperature management? Have they had a recent major surgery, a traumatic arrest? Are they pregnant? Are they equal to or less than 16 years old? Do they have a terminal illness or are they a DNR patient? Is the downtime greater than 30 minutes? The symptoms is a sustained return of a pulse or ROSC that's greater than 5 minutes. So, for ALS support, we want to place an endotracheal tube or an I-gel airway if it hasn't already been done, confirm a placement with an end-tidal CO2 detector, and perform continuous CO2 capnography. Make sure end-tidal CO2 reading is greater than 20 millimeters per mercury, and be careful not to hyperventilate. The targeted end-tidal CO2 should be 35 to 45 units. Perform a brief neural exam, checking their GCS and their pupil size, and record it in the patient care report. Obtain baseline tympanic temperatures and expose the patient to the underwear. If ice is readily available, apply ice packs to the axilla and groin. If able, establish bilateral ACIVs. An IO line can be used if peripheral IV access cannot be obtained. If ice packs are available, apply bilateral ice packs to the axilla or the axillary artery and the groin, the femoral artery. Monitor a patient for shivering, administer diazepam, Valium 5 to 10 milligrams IV to treat the shivering should it occur. Administer cold, 4 degrees Celsius normal saline boluses, wide open, at 30 milliliters per kilogram per IV or IO, up to a maximum of 2,000 milliliters. The goal is to use pressure infusion to get 1,000 milliliters of cold saline infused within 15 minutes. Start 2 large bore IVs if possible. Frequently reassess breath sounds for evidence of pulmonary edema. Administer norepinephrine drips at 8 to 12 micrograms per minute IV to sustain a blood pressure of greater than 100 units. Transport the patient to the emergency department at either Christus Spawn Shoreline, Bay Area, or Doctors Regional, where targeted temperature management protocols are in place. Note: if there is sustained loss of pulse and blood pressure during cooling, discontinue the therapeutic hypothermia and revert to the appropriate protocol. Each 1,000 cc's of cold saline bolus should decrease the patient's temperature by 1 degree Celsius. Eligible patients will be maintained at a hypothermic temperature of 32 to 36 degrees Celsius for at least 24 hours post-cardiac arrest. Continue to address specific differentials associated with the original dysrhythmias. All right, now we're moving to the trauma section. Yippee, yippee, woo, woo. Okay. This, I haven't checked the time of the recordings yet. I'm guessing we're around the 15-minute mark or so, but that's okay. So, general trauma management. To introduce this topic, it's a quick and accurate initial assessment of the traumatically injured patient. It's very essential to do so. You want to evaluate and manage any airway and breathing problems first, followed by an assessment of the circulation. Then, perform a brief neurological examination with complete exposure of the patient. Always remember to protect the axial spine with inline stabilization. With major trauma, one of the most important goals of pre-hospital management is a brief scene time. Load and go. Rapid patient assessment and rapid patient transport to a trauma center capable of resuscitation and definitive management of the victim. Spend as little time as possible to evaluate your patient, perform life-saving measures, and prepare the patient for transport to the hospital. Optimally, all scene times for critically injured trauma patients should be less than 10 minutes, unless extenuating circumstances, such as extrication, multiple patients, etc. Do not delay scene times on non-life-saving procedures. In most cases, IVs can be started en route to the hospital unless IV access is needed for medication administration. EMS personnel must accept the reality that stabilization of the severely injured patient may be impossible. Time should not be wasted on elaborate assessments, splints, and dressings. Often, major trauma is a surgical disease, and rapid transport to the closest appropriate hospital is vital in all unstable patients. See Trauma Criteria, page 13. Request additional resources, additional ambulances, rescue equipment, etc. early in the scene assessment. Always evaluate geriatric trauma patients with a high index of suspicion. Often, occult injuries are more difficult to recognize and patients can decompensate unexpectedly with little warning. For basic life support, establish scene safety. Check their ABCs. Assess adequacy of perfusion, their mental status, and a character of the pulses and their capillary refill. Stabilize the cervical spine with manual inline stabilization. Apply high-flow O2 via a non-rebreather if there's an altered mental status, shortness of breath, or severe multi-system traumas. Assist with the BVM as needed. Control gross external bleeding with direct pressure. Remember to also hold pressure over penetrating trauma sites, such as gunshot wounds and stab wounds, to stop any internal bleeding into the tissue. Perform a brief neurological exam. Check their level of consciousness, their AVPU, which is if they're alert, verbal, painful, or unresponsive. Pupil reactivity and gross motor function. Motion restrict the cervical spine as needed with the long backboard, head blocks, C-collar, straps, etc. See the spinal trauma protocols on page 104. Obtain vital signs. Get your pulse oximetry, expose the patient and perform a secondary survey head to toe. Preserve body heat when possible. Immobilize and splint obviously fractured extremities. Obtain a history. Utilize a sample mnemonic, which is signs and symptoms, allergies, medications, past medical history or surgeries, last oral intake, last menstrual period if applicable, and the event of the accident. For advanced life support, advanced airway control, you can consider an intubation or an iGel as needed for an unresponsive patient with a GCS less than an 8. If a patient has a suspected tension pneumothorax, shortness of breath, hypotension, decreased breath sounds, and hyperresonance to percussion, perform a needle thoracostomy, also known as a pleural decompression. Refer to the pleural decompression appendix on page 175. The patient must be hypotensive. Their blood pressure has to be less than 100 units for a needle decompression. Establish IV access via a large AC bore needle, or an external jugular site. Establish a second line if possible if the patient is hemodynamically unstable and time allows. Administer IV fluids via a normal saline bolus from 250 to 1,000 milliliters or 20 milliliters per kilogram for a child if the patient is hypotensive or tachycardic. Titrate the IV fluids to keep the blood pressure greater than 100 units. Monitor an EKG rhythm. Refer to specific dysrhythmia protocol as needed. You can administer morphine sulfate at 2 to 10 milligrams or 0.1 milligram per kilogram to a child with a slow IV push or intramuscularly, or you can administer fentanyl at 50 to 100 micrograms. If a patient has an isolated extremity trauma, do not administer morphine if the patient has abdominal pain, trauma, chest pain trauma, or altered mental status, unless it is absolutely necessary to facilitate intubating a patient. See the head injury protocol on page 101. If morphine is administered, the patient must be on the cardiac monitor and pulse oximetry. If any question exists about the proper use of morphine in extremity trauma, contact medical control. Administer TXA or tranexamic acid at 1,000 milligrams IV over 10 minutes. If the patient meets the criteria for administration, see TXA protocols on page 186. Assess the GCS score and the revised trauma score en route. Notify the receiving hospital early with the patient report so that the trauma team can assemble. Reassess the vital signs frequently. Note, remember not to overlook potential chest and abdominal injuries, which are often more life-threatening than the obvious deformed limb. Anyone can recognize a severely displaced limb, but it takes a hyper-vigilant pre-hospital provider to recognize a potentially more serious injury in the abdomen or chest. Do not overlook the possibility of child abuse and pediatric trauma. That's actually really huge. All lacerations should have direct pressure held onto them. The first responder should hold pressure onto the wound and not place a formal bandage until the ALS crew has visually assessed the wound. The paramedic is ultimately responsible for the wound and needs to visualize them. Remember that penetrating lacerations, i.e. gunshot wounds and stab wounds, may still be bleeding internally, even if external bleeding is absent. Always hold direct pressure on these wounds. For some severe wounds, it may not be possible to hold direct pressure on the wound. For these large defect wounds, the goal is to stop the bleed, you can see it right here, and wound packing can be employed in an attempt to reduce or stop the bleeding. The concept of tourniquet the limbs, pack the junctions, and seal the box can be used to treat the severely injured trauma patients. In a single MVC or motor vehicle collision, always consider the 6 S's as a possible cause for the wreck. Syncope, which could be caused by a dysrhythmia, or an MI, which is a myocardial infarction, a seizure, sugar, which is hypoglycemia, suicide, slush, which is intoxication, and stroke. Never remove any penetrating objects from the body unless the object is impaled into the face and impairs effective airway management. For a suspected open book pelvic fracture, both lower extremities will be externally rotated to look like frog legs. A bed sheet can be wrapped around the pelvis to reduce the volume of the pelvis. The device or sheet should be slid beneath the arc of the lower back and over the greater trochanters, then tightened to an appropriate tension is achieved. Special trauma considerations for eye injuries. For their history, we want to see if they have contacts, glasses, mechanism of injuries, any prior eye surgeries, history of unequal pupil size, and a history of eye trauma. For the physical examination, we want to check visual acuity, visual fields, the pupillary reflex, the shape of the pupil, and the extraocular movements. For differential diagnosis, we want to check for a corneal abrasion, corneal ulcers, chemical burns, foreign bodies, lacerated or open globes, welder's burns, and UV keratitis. For BLS and ALS treatment, do not remove a foreign body from the eye. Cover the patch and transport. Support an impaled object in place and do not apply pressure to the eye. If there is an open globe or penetrating injury to the eye, the pupil will often appear teardrop shaped. Use a cup or hard cover to protect the eye. Never apply any pressure to the eye. Often it is best to patch both eyes to prevent extraocular consensual movement. However, many patients will become anxious in the ambulance if both eyes are patched. If a potential chemical burn has occurred, determine if it was an alkali or acid. You can get the name and bring the bottle to the ED if possible. The eye should be immediately irrigated copiously with tap water or saline using gloved hands. Hold the patient's eyelid open and irrigate for 15 minutes. Normal saline should run through a 10-drop IV tubing, which can be used for irrigation at the scene and en route. It is not necessary to rush patients with isolated chemical injuries to the eyes directly to the hospital. The definitive treatment is copious irrigation of the eyes, and it should always be initiated as soon as possible, either on scene or en route. For hemorrhage control, you want to do direct wound care. Use proper BSI or body substance isolation protocols. Remove any sharp, loose fragments of glass or other foreign substances which, if pressed upon, could result in further injury to the patient or rescuer. Impaled objects such as knives or etc. should not be removed, but should be stabilized in place to prevent further movement or deeper insertion. Cover the bleeding site with a gauze dressing and apply firm, direct pressure over the wound. To be the most effective, you want to apply pressure directly so that the injured vessels lie between where the pressure is applied and an underlying bone. Coban can be used to make an effective pressure dressing. Elevate the limbs such that the wound is above the level of the heart. For tourniquet use, if bleeding control of an injured extremity cannot be adequately achieved with direct pressure or Coban, then using a tourniquet device can be considered. Apply the tourniquet to the injured extremity at least 1 inch proximal to the bleeding site. Tighten the windlass per manufacturer instructions until the hemorrhage and or the distal pulses in the affected extremity disappear. Secure the tourniquet per manufacturer instructions. Make note of the application time and continuously reassess for hemostasis. The tourniquet should be used only in traumatic situations of severe hemorrhage that cannot be controlled by less aggressive measures. A tourniquet should not be used for a bleeding dialysis shunt. So please remember this, do not use a tourniquet for dialysis shunt. Israeli trauma dressing use. Use the Israeli trauma dressings for bleeding wounds that don't require a tourniquet. This may include junctional wounds, which are near the shoulders and groins, and venous bleeds, which are dark, oozing blood. If needed, you can pre-pack the wound with gauze. Place a rectangular gauze pad over the wound and continue holding pressure. Wrap the elastic band around the wounded area and wrap around the edges of the gauze and then loop the elastic through the pressure applicator. Pull the pressure applicator back over the wound. Wrap until one runs out of elastic band. Apply pressure as one wraps. Twist the elastic band as one passes over the pressure applicator to help apply pinpoint pressure. The Israeli trauma dressing can be used as a tourniquet, and if needed, and a dedicated tourniquet is not readily available. For hypovolemia or hypotension, for BLS and ALS treatment, follow the above general trauma management guidelines. Hypotensive patients always need high flow O2 and intubate as needed if there are an ALS crew. Control external hemorrhage to avoid further blood loss, including scalp lacerations. Scalp lacerations without control of the bleeding with direct pressure have the potential to be fatal, especially in children. Remember that all penetrating trauma, such as gunshot wounds, stab wounds, etc., need direct pressure even if no external hemorrhage is visualized. If it's an ALS crew, establish 2 large bore IVs and run normal saline in wide open 250 mLs or 1000 mLs or 20 milliliters per kilogram for a child IV boluses, using pressure bags if available. Titrate IV fluids as needed to maintain a systolic blood pressure greater than 100 millimeters per mercury. Bandage and splint any fractures to prevent further tissue trauma and bleeding from the bone fragments. Assess and treat for causes of hypotension, such as a tension pneumothorax, a pericardial tamponade, chest trauma, abdominal trauma, spinal shock, cardiogenic shock, or heart attack. Obtain a 12-lead EKG if available, and a cardiac etiology is being considered. Rapid transport is necessary, and a closed head injury is almost never the cause of hypotension. Always look for another cause, such as the chest, abdomen, and pelvis. Administer TXA 1000 milligrams IV over 10 minutes if the patient meets the criteria for administration. See page 186. For a traumatic arrest. For BLS and ALS treatment, if obvious signs of death are on arrival, such as decapitation, crushed head, asystole on the monitor, do not attempt resuscitation. If patients have vital signs by first responders or movement, or if the patient is greater than 20 weeks pregnant, possibility of fetal survival with an emergency C-section or hospital arrival, Proceed with resuscitation per general trauma management on page 87. If a patient has sustained penetrating trauma and has vital signs in the field, proceed immediately to the trauma hospital. A small percentage of penetrating trauma arrest can be saved with emergent thoracotomy and cross-clamping of the aorta. That's probably not how you pronounce that. All penetrating chest wounds, traumatic arrest, should receive bilateral pleural needle decompressions. If patients have sustained a blunt traumatic arrest and still in arrest after CPR, intubation, and IV access with IV fluid bolus, and ACLS medications have been administered, then contact medical control for the possible chance of a field pronouncement. This situation will probably not occur as much as scene time should be less than 10 minutes. If the arrest is being worked on, it is better to load and go, and the mortality rate of a blunt traumatic arrest can potentially approach 100%. If a question exists, always err on the side of continuing the code and transporting the patient to the hospital. Always contact medical control for guidance as needed. For abdominal traumas, to introduce this, it's blunt abdominal trauma that often is caused from solid organ injuries, such as the liver or spleen laceration, mesenteric vessel vascular injuries. Penetrating abdominal trauma can often cause bowel or vascular injuries. The presence of seatbelt abrasions increase the incidence of intestinal perforations, especially jejunal perforations in children. The history, you want to check to see the mechanism of injury, the speed of the vehicle, the height of the fall, etc. Was the patient wearing a seatbelt or a helmet? A vehicle deformity, such as a bent steering wheel, a starred windshield, and a loss of consciousness. The symptoms should be abdominal pain, and blah, 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 blah. For basic life support, you want to follow the general trauma management protocols as outlined on page 87. Keep the patient's NPO, nothing by mouth. If an evisceration exists, cover the exposed parts with saline soap gauze or sterile burn sheets and keep the area moist. For ALS support, follow the general trauma management as outlined on page 87 with the following additional notes specific for abdominal trauma and also pregnant trauma patients. Administer TXA 1000 milligrams over 10 minutes. If they meet the criteria, see page 186 for the criteria. Notes: significant abdominal trauma is associated with the high mortality, especially with elderly patients. Always assume tachycardia in the normotensive trauma patient is compensated shock. Remember, tachycardia will usually be seen before hypotension. It is important to frequently reassess vital signs, a minimum of every 5 minutes. There is a debate about the optimal systolic blood pressure for a hypotensive trauma patient and the role of aggressive IV fluid administration in the pre-hospital resuscitation of the trauma patient. Does increasing the blood pressure too high without immediate surgery wash out and dislodge the clots, or does it increase perfusion? There is no definitive human studies yet, and the current practice will be to continue administering IV fluids as necessary to keep their blood pressure greater than 100 units. It is clear that the benefit of IV fluids in a trauma patient is much less than that of high-flow O2, including early intubation, rapid transport to the hospital, and early surgical interventions. Patients with seatbelt abrasions across their abdomen have an increased incidence of intestinal perforations, and this finding should not be considered benign. Lower extremity IV lines are relatively contraindicated if serious abdominal injury is suspected. Pregnant trauma patients. Always apply high-flow O2 to the pregnant trauma patients. This fetus is much more sensitive to hypoxia and hypovolemia than the mother. Pregnancy alters vital signs as well as response to hypovolemia. Normally, the blood pressure will be lower, normally with a slightly increased heart rate. Also, changes in hypovolemia are often delayed. Deceleration forces can cause abruptio placenta, a placental separation from the uterine wall. All obviously pregnant patients greater than 20 weeks should be transported to the hospital for subsequent fetal monitoring. Ascertain the presence of fetal movement, patency of the bag of water, which is the amniotic sac, and the presence of any vaginal bleeding. Avoid supine positioning in obviously pregnant patients. When necessary to perform spinal motion restriction, secure the patient precisely and then turn the backboard on its side to assume a left side down at 45-degree angle to keep pressure of the gravid uterus off the inferior vena cava which can decrease the venous return to the heart, causing hypotension. For burns, either chemical, electrical, or thermal, the key to burn treatment is to stop the burning. While protecting yourself, remove burning or contaminated clothing. Use caution in removing clothing that is stuck to the skin as a result of burning. Certain dry chemicals, such as lime and soda ash, may be harmful when wet, can form a corrosive substance. When possible, wipe and brush the dry chemicals off without using water. Phenyl or carbolic acid is not water soluble and will not be removed by water irrigation. It is alcohol soluble, and affected areas should be washed with an alcohol product such as an isopropyl alcohol prep pad prior to prolonged flushing with water. Use cold water to stop the burning process and to limit the depth of injury. Do not apply ice to burns, as burn patients are susceptible to hypothermia. It is very important for burn patients to maintain a normal body temperature. Do not apply ointment or solutions to the wound in the field. In the case of electrical burns, it is important to determine alternating currents or AC versus direct currents DC, high voltage greater than 1000 volts versus low voltage, and the duration of contact with the source. In severe electrical burns, remember, most injuries are internal. Fatal dysrhythmias may occur early if the heart has been electrically injured. Maintain a high level of suspicion for an inhalation injury in patients with throat pain, voice hoarseness, dysphonia, mucosal burns, or cough. The presence of singed nasal hairs is no longer considered an accurate factor by itself for a patient in need of emergent intubation. Early intubation is required when the patient has sustained a significant inhalation injury. Depending on the mechanism of injury, always evaluate for underlying multisystem injuries in a trauma patient. For the history, determine the nature of the burn, what caused the burn, the duration of the exposure, whether the patient was in an enclosed space, the time of the burn, the possibility of smoke inhalation, whether chemicals were involved, and whether any related trauma occurred. For BLS or basic life support, watch out for scene safety. Wear PPE, extinguish the flame as needed, and have dispatch contact the electric department as needed. Initiate a hazardous material response if indicated. Watch out for ABCs, suction the patient if necessary. Apply oxygen. All patients exposed to fire should be treated with high flow O2 via non-rebreather mask. They may have potential carbon monoxide exposure and an elevated carboxyhemoglobin level. Obtain vital signs. Use saline to contaminate the skin as needed. Make sure the skin is blotted dry after decontamination. Apply moistened gauze or a sterile saline dressing if the burn surface area is 2nd degree or 3rd degrees and is less than 10%. If the burn body surface area is greater than 10%, use a dry burn dressing or clean dry sheets to avoid hypothermia. Spinal motion restriction the patient if needed, and assess the burned area using the rule of nines for only 2nd or 3rd degree burns. Do not include 1st degree burns, that's in erythematous areas like sunburns, in the percent determined. See the chart at the end of protocol, page 97. Notice that the patient, if they're pediatric, have different percentages given their different body proportions. Monitor their pulse ox. Splint fractures as needed. Keep the patient warm, as burn patients are very susceptible to heat loss. Remove rings or other constrictive jewelry if the hand is burned, as swelling can be rapid. Make sure the jewelry is transported securely with the patient and have a witness observe you removing your jewelry and packaging it with the patient. For ALS or advanced life support, expect airway problems whenever the patient has burns to the face, was exposed to smoke in an enclosed area, or exposed to toxic fumes. Check the patient for coughing, tachypnea, hoarseness, or wheezing. If the patient has any of the above with carbonaceous or black sputum, be very concerned about a rapid upper airway swelling. It is best to intubate these patients early on. Establish IV or IO access. Avoid starting an IV in a burned extremity or distal to any circumferential extremity burns unless it is absolutely necessary. Administer IV fluids of a normal saline or lactated ringers if you have them at 500 milliliters per hour in patients 14 years and older, at 250 milliliters per hour for 6 to 13-year-olds, and 125 milliliters per hour in patients 5 years old and younger, if significant burns are greater than 10% of the body surface area. Maintain a systolic blood pressure greater than 90. IV fluids will usually be switched to lactated ringers in the emergency department. as large amounts of normal saline, greater than 3 liters, can cause a hyperchloremic metabolic acidosis. Pre-hospital IV fluid should be kept to maximum of 500 milliliters per current American Burn Life Support ABLS guidelines. Monitor an EKG rhythm and treat dysrhythmias as needed. The patient is wheezing, administer albuterol 5 milligrams or 2.5 milligrams to a child via nebulizer. If pain control is needed and there's no possibility of abdominal, chest, or head trauma, administer morphine sulfate at 2 to 10 milligrams or 0.1 milligram per kilogram for a child, slow IV push, or intramuscularly, or fentanyl 50 to 100 micrograms. Midazolam or Versed can be administered at 2 to 5 milligrams or 0.1 milligram per kilogram via IV, intramuscularly, or mucosal atomizer device, which just means intranasally, can be administered with morphine as needed for patients in severe pain. It is imperative that the patient must be placed on a continuous pulse ox with close cardiac monitoring if midazolam and morphine are used. Note: for critical or serious burns, these may require subsequent transfer to a burn center. If it's greater than 5% to 15% of a total body surface area at a second degree or third degree burn, third degree burns that are greater than 5% total body surface area burns for any age group, circumferential burns of extremities, electrical or lightning injuries, suspicion of abuse or neglect, inhalation injuries, chemical burns, or burns of face, hands, perineum, or the feet. Shock in the very early presentation of a burn is often not associated with the burn. Always consider other life-threatening injuries. Always consider other medical or traumatic cases or causes for hypotension in a burn patient and treat them accordingly. Make sure the major trauma is treated first and then the burns can be treated after. The bolusing of IV fluids, i.e. the Parkland formula, is no longer routinely recommended in burn resuscitation without evidence of concomitant, I have no idea how to pronounce that, traumatic contributions of blood loss. Consider the possibility of child abuse in children with an atypical history and physical examination. Circumferential burns to the extremities are danger due to the potential for vascular compromise or secondary to soft tissue swelling. If chemicals are involved, attempt to identify the source. Any chemical information or material safety data sheet or MSDS sheet should be brought to the hospital with the patient. Do not try to neutralize an acid or alkali burn with the opposite chemical of an alkali or an acid. For hydrofluoric acid exposure, with patients exposed to less than 50% hydrofluoric acid, their symptoms may be delayed for up to 24 hours. Pain will be out of proportion compared to the physical findings at the burn site. Assure the patient that there's proper decontamination that has been performed prior to patient contact. Assure adequate airway ventilation and oxygenation occurs. Monitor cardiac rhythms. Obtain a 12 lead for burns greater than or equal to 2% of the total body surface area. Severe systemic effects may be seen with burns greater than or equal to 2% total body surface area and with ingestion or inhalation. Hypocalcemia, hypomagnesemia, and hyperkalemia may occur and lead to cardiac dysrhythmias. Treat cardiac changes and seizures per paramedic standing orders. If there are any burns encountered after an HF or hydrofluoric acid exposure, which is rare, it is best to peel and drain these particular blisters, HF only, as they may contain residual HF in their series of blister fluid. For hydrofluoric acid treatment, for skin burns, apply topical calcium gluconate 2.5% gel after copious skin irrigation. Massage calcium gluconate 2.5% gel into the affected areas. Reapply until pain is relieved. Calcium gluconate works by binding fluoride ions. Ice can be applied to hydrofluoric acid burns if it is available and is advocated by some as an additional treatment modality. Consider IV calcium gluconate at 1 to 2 grams of IV titrated to control cardiac dysrhythmias. For ocular hydrofluoric acid burns, irrigate with water or normal saline for 15 minutes. For inhalational hydrofluoric acid exposure, administer high flow to, and as soon as possible, administer 2.5% calcium gluconate solution by inhalation using a nebulizer. 0.5% solution is made by mixing 1 gram 10 ml of calcium gluconate at 10% with 20 milliliters of normal saline. For degrees of burns, For a first-degree burn, you're going to see erythematous or reddening of the skin, no blisters. They're going to have a sunburn-like burn with skin blanches with direct pressure. It's going to be painful. Second-degree burns are going to be red and blisters will be present. This will also be painful. For third-degree burns, they may be white, leathery, with thrombosed vessels seen beneath the skin. Skin may not be blistered, it may be charred instead. The skin does not blanch with direct pressure, and this is not painful, which is a horrible sign. Here's an example of the rule of nines. For chest trauma, follow the general trauma management protocols on page 87 with the following additional considerations listed below if chest trauma is found. Monitor the EKG rhythm closely. Patients with a cardiac contusion can have significant ectopy. If a traumatic arrest is secondary to possible chest trauma, perform bilateral pleural needle decompressions. See page 175. All penetrating chest wounds below the nipple line must be suspected of also having entered the abdominal cavity. For rib fractures, they may have crepitus or subcutaneous air on physical examination. The presence of subcutaneous air on exam often indicates the presence of a pneumothorax. However, very few pneumothoracics are under tension. Remember to only perform a pleural needle decompression if the patient has decreased breath sounds with hypotension. Always suspect a pneumothorax if rib fractures are felt. The chest can be splinted with a pillow in the pre-hospital setting for patient comfort. For a flail segment, 2 or more adjacent ribs are broken in 2 or more places. You'll see paradoxical movement of the flail segment with respirations. Always inspect the motion of the chest wall closely. The chest can be splinted with a pillow in the pre-hospital setting for patient comfort. For a hemothorax or a simple pneumothorax, they will get hyporesonance to percussion with a hemothorax with blood and hyperresonance to percussion with a pneumothorax, which is air. Monitor the patient closely for the development of a tension pneumothorax, which will present with JVD or jugular vein distension, hypotension, tracheal deviation, and treat with pleural decompressions as needed. For a tension pneumothorax, perform a pleural needle decompression if indicated as outlined in the appendix on page 175. The patient must have hypotension, decreased breath sounds on the affected side, hyperresonance, and shortness of breath. Additionally, the patient may have JVD, which is jugular vein distension, or tracheal deviation. A sucking chest wound. Cover the wound with an occlusive Vaseline gauze on 3 sides. Look for an exit wound. Do not forget to look carefully in the axilla and monitor closely for the development of a tension pneumothorax. For an airway obstruction, directly visualize and use the Magill forceps to remove a foreign body if able. See page 20 for airway obstruction protocols. For a pericardial tamponade, you'll see Beck's triad, a narrowed pulse pressure with the systolic and diastolic pressure becoming closer, hypotension, jugular vein distension, and muffled heart sounds. For a pericardial tamponade, rapid transport to the hospital is appropriate. Now, for extremity trauma, amputations, or crush injuries. To introduce this topic, always expose the injured extremity so proper assessment can be accomplished regardless of the extent of the injury. Cut away clothing on the involved extremity as needed. For general principles, protect any open wounds, position the limb, immobilize the injury, including the joint above and the below injury site. Check neurovascular functions, such as their pulse, motor function, and sensation in the distal extremities before and after splinting. Remove gross debris, such as gravel, grass, etc., from the wound before bandaging. For the history, you want to check the type of injury, the mechanism of injury, if it's crush, penetrating, amputations, a fall, or a motor vehicle collision, the time of injury, and if it's an open versus a closed wound. For symptoms, you want to check to see if there's pain over an extremity or decreased range of motion, a deformity, diminished pulse, or a capillary refill. For basic life support, you want to check airway, breathing, circulation. You want to apply oxygen as needed, maintain inline cervical stabilization as needed, obtain vital signs, control hemorrhage as needed, apply sterile dressings to open fractures, assess distal neurovascular motor status, splint and immobilize the extremity in the position found. If adequate distal pulses are present, do not attempt reduction in the field unless the distal circulation is acutely compromised. If it's blue and cold, attempt reduction with firm inline traction. See the repositioning injured extremities with compromised circulation below. Apply a traction splint for closed femur fractures. This helps control bleeding, decrease pain, and helps prevent a fat embolus originating from the bone marrow. The traction splint is contraindicated in hip dislocations, knee dislocations, pelvic fractures, open femur fractures, and a second fracture distal to the knee at the tibia, fibula, and the ankle. Reassess distal neurovascular motor function after the extremity has been splinted. Always assess neurovascular motor status before and after immobilizing a suspected fracture or dislocation. You want to apply ice to a musculoskeletal injury if it is available and if the injury is less than 12 hours old. If an amputated part is encountered, gently irrigate the amputated part with normal saline and wrap in moistened sterile gauze. Place in an airtight plastic bag or a specimen cup and put the bag or cup in an ice water bath. Transport the amputated part with the patient to the hospital. Never allow amputated parts to come into direct contact with ice to prevent freezing. Cover the amputated stump with a wet sterile dressing and apply uniform pressure across the entire stump. Do not use a tourniquet unless bleeding cannot be controlled with adequate direct pressure. Apply pulse oximetry if needed, and whenever possible, elevate the injured extremity above the level of the heart once it's splinted. For repositioning injured extremities with compromised circulation. Injured extremities with apparent fractures should be repositioned only if there is a loss of circulation to the distal extremity if it's blue and cold. Grasp the limb firmly with both hands and exert longitudinal attraction with an attempt to restore normal anatomic positioning. After an injury has been repositioned, confirm the presence of pulses and capillary refill in the distal extremity. If no return of blood flow and color, make one more attempt to reposition the injured area. Maintain traction until the splint has been applied and secured. For ALS or advanced life support, establish an IV access. Start IV fluids of normal saline at 250 to 1,000 milliliters or 20 milliliters per kilogram for a child of an IV bolus as needed for signs of hypoperfusion or long bone fractures. Otherwise, start IV fluids at 60 mL per hour and establish a saline lock. Monitor a 12 lead. Administer morphine sulfate, 2 milligrams to 10 milligrams or 0.1 milligram per kilogram to a child with a slow IV push or intramuscularly, or fentanyl at 50 to 100 micrograms for severe pain and an isolated extremity trauma. Morphine may be administered prior to splinting and immobilizing an injured extremity if time allows and the patient is in severe pain. For prolonged entrapment with a significant crush injury, administer sodium bicarbonate 1 amp or 50 milliequivalents IV prior to the extrication to help minimize the release of potassium from crushed cells. They can be caused potentially by deleterious hyperkalemia, and it can cause these effects on the heart. The sodium bicarbonate administration should ideally be done 10 to 15 minutes before the extrication and may need to be repeated depending on the situation and the amount of crushed tissue. Emergently transport any injury with continued vascular compromise. Note: remember that a midshaft femur fracture can cause 1,500 milliliters of blood loss, while a pelvic fracture can result in greater than 2,000 milliliters of blood loss. If a patient has evulsed a permanent tooth, replant the tooth back into the socket as soon as possible after gently irrigating the tooth with normal saline. Make sure the tooth is in proper orientation before replanting. Irrigation of the tooth should be done carefully with no debriding or scrubbing of the tooth that can remove the delicate periodontal ligament. Avulsed primary baby teeth should not be replaced. For head trauma, the treatment goals are high flow to intubate early as needed, and spinal motion restriction along with rapid transport. For the history, you want to gather the time of the injury, the mechanism of injury, a loss of consciousness if there is any, and the duration, any seizure activity, the type and duration, nausea or vomiting since the injury. Did they wear a helmet if it's applicable? Did they lose any sensation or movement? Was a seatbelt used? And did airbags deploy? For symptoms, we're looking for an altered mental status, headaches, weakness, visual changes, nausea or vomiting, neck pain, and seizures. So, for BLS or basic life support, you want to determine the responsiveness via the AVPU, which is alert, verbal stimuli, painful stimuli, and unconsciousness. We want to check out their ABCs. We want to apply oxygen, high flow to if they have an altered mental status, assist with the BVM as needed, use an NPA or an OPA also as needed, maintain strict inline cervical stabilization, assume a high index of suspicion for a C-spine injury on all head injury patients. Spinal motion restriction should be considered on all head trauma patients. Control external hemorrhaging with direct pressure. Obtain vital signs, check their blood sugar levels, establish pulse oximetry, and refer to altered mental status protocols on page 25 as needed. For advanced life support, we want to intubate the patient as needed, maintaining a strict inline cervical spine immobilization. Consider intubating patients that have a GCS of less than 8. If intubated, bag with respiratory rate of 16 breaths per minute to keep the PCO2 at 30 to 35 units. Use continuous ETCO2 monitoring, also known as capnography. Mild hyperventilation in the pre-hospital setting will cause vasoconstriction that will decrease the cerebral blood flow and can decrease cerebral edema and lower intracranial pressure. Head trauma patients may need to be intubated, often having significant jaw clenching, which prevents intubation. In these cases, support with BVM through an NPA and transport the patient to the hospital where paralytics are available. Avoid using an NPA if the patient has suspected nasal fractured, mid-face fractures, or basilar skull fractures. Midazolam, or Versed, 1 to 5 milligrams IV for adults only, or IO, IM, or MAD device, or morphine sulfate, 2 milligrams to 10 milligrams, 0.1 milligrams per kilogram for a child with a slow IV push, or IO or IM, or fentanyl, 50 to 100 micrograms, may be administered to relax a patient's jaw muscles for an intubation attempt. Contact medical control if repeat doses are needed. Monitor a 12 lead. You can utilize lidocaine 1.5 milligram per kilogram and can be administered 30 to 60 seconds before intubating if IV access can be established quickly. Lidocaine will help block the intracranial pressure rise induced by the laryngoscope reflex-mediated pathway. Establish IV access with normal saline at 60 mL per hour with a saline lock. Do not administer IV fluids to a head trauma patient unless the patient is hypotensive or showing signs of hypoperfusion. Large volumes of IV fluid in a closed head injury may worsen the cerebral edema. If spinal shock is suspected, proceed with IV fluids of normal saline at 250 to 1000 mL or 20 milliliter per kilogram for an IV bolus. Consider norepinephrine drip at 8 to 12 micrograms per minute, IV administration for an adult patient to maintain a systolic blood pressure greater than 100 units. If blood glucose is less than 70 units, administer D10 25 grams IV or 0.5 grams per kilogram for a child. Consider midazolam or Versed at 1 to 5 milligrams with a slow IV or IO, IM, or MAD device push for adults only, and morphine sulfate 2 milligrams to 10 milligrams or 0.1 milligram per kilogram slow IV push or IO, IM, or fentanyl 50 to 100 micrograms for sedation to help with endotracheal tube tolerance as needed. You can elevate the head of the backboard 15 to 30 degrees if able to, and continually reassess mental status and vital signs en route. Changes in the level of consciousness are very important to monitor and document. If the patient seizes, refer to the seizure protocol on page 61 and refer to the altered mental status protocol as needed on page 25. Note, for decorticate posturing, it's abnormal flexion of the arms with a lesion above the brainstem. For decelerate posturing, it's abnormal extension of the arms, and it usually is from a lesion below the brainstem. Hypotension after an isolated head trauma is very unusual. Always look for other sources, especially the chest, abdomen, and pelvic injury. Head injury patients are often combative and may have alcohol or drugs on board. Never assume a combative patient with alcohol in the breath is just drunk. Look for signs of a closed head injury. Agitation or restlessness may be due to hypoxia, a lack of oxygen, and not just the traumatic insult or mind-altering drugs. Battle signs or raccoon eyes usually take hours to develop and usually will not be seen acutely in the pre-hospital environment. High flow O2 via a non-rebreather mask is very important as oxygenation reduces a secondary brain ischemic insult after the initial injury. Head lacerations can be fatal, especially in children. Always hold firm direct pressure unless an open skull fracture with exposed brain matter or an obvious depressed skull fracture. Patients with helmets on, either they're playing football or they're riding a motorcycle, should be immobilized with the helmet on if it fits securely. If it's loose and good cervical alignment cannot be obtained, or if access to the head or airway is needed, the helmet may be removed with 2 to 3 people assisting. Any potential obstructive barriers, such as a face mask or shield, should be removed or cut away from the helmet. Refer to Spinal Trauma Protocol in page 104. Cushing's response may be seen in a severe head injury, which is an increase in blood pressure with decreasing pulse, as well as irregular respirations. For traumatic causes of increased intracranial pressures, if you see an epidural hematoma, it usually results from an injury to the middle meningeal artery, a direct blow over the ear. The patients will have a decreased level of consciousness, a lucid interval, and then unconsciousness. For a subdermal hematoma, it's an injury to the bridging veins under the dura. It's often a more subacute onset. A subarachnoid hemorrhage, which is an injury to the cerebral arterial vessels. An SAH can occur after an aneurysmal rupture or after trauma. And a shear injury, which is a small vessel injury after a deceleration injury with coupe and countercoupe. Now, here's the GCS scoring that goes over eye-opening, verbal response, and motor response. You can pause it if you want to learn it. For spinal trauma or spinal motion restriction, to introduce this topic, if not properly recognized and managed in the field, spinal cord trauma can result in significant lifelong injury and impairment. A high index of suspicion must be maintained for any patient with significant signs or symptoms of head injury, a decreased level of consciousness, or a possible mechanism such as a major fall, a motor vehicle crash, and a diving accident. The patient's ability to walk should not be a factor in determining whether a patient needs spinal motion restriction. Up to 10% of unstable spinal injuries may be ambulatory on scene. For the history, you want to gather a mechanism of injury, prior spinal or back surgeries, a loss of consciousness, and seizures. For symptoms, you're looking for head pain, neck or back pain, paralysis, numbness to any extremities or anywhere in the body, nausea or vomiting. For BLS, we're going to worry about our ABCs. Look for diaphragmatic breathing in a cervical spine cord injury. The patients will only be able to breathe with their diaphragm, as they have lost intervention to their intercostal muscles that expand the chest cavity outwards. Apply oxygen, high flow if decreased level of consciousness or shortness of breath. Control any external hemorrhage with direct pressure. Spinal restrict the patient prior to moving them using a backboard, C-collar, and appropriate straps such as a safety belt, spider straps, webbings, cravats, etc. Head blocks. Always immobilize the patient with the straps first and then secure the head blocks to the board. This is in case the patient vomits and needs to be turned quickly. Obtain vital signs. A patient may have hypotension with relative bradycardia if in spinal shock. Check a blood glucose and check their SpO2 levels. For ALS or advanced life support, establish an advanced airway as needed. Always maintain inline cervical stabilization. Establish IV access. Start fluids if the patient is hypotensive, maintaining a blood pressure greater than 100. Monitor the 12 lead. Reassess frequent vital signs every 5 minutes or less. If an adult patient remains hypotensive after IV fluid bolus and spinal shock is suspected, consider administering a norepi drip at 8 to 12 micrograms per minute to titrate their blood pressure greater than 100 units. Some special notes. It is best to spinal motion restrict the patient with the helmet in place as long as it fits snugly and no access is needed to the patient's head or face. Extra padding should be placed under the shoulders to maintain good inline cervical alignment. Remove any face shields that may impede good access to the airway. Remove the helmet using ideally 3 people if the helmet blocks management of the airway control, head injury treatment, or if the helmet is too large and does not fit securely for effective C-spine restriction. For a paramedic clearing of C-spine in the field, spinal motion restriction of the patient may be omitted if all of the following conditions exist and are documented clearly in the patient report. There are no exceptions. Strict adherence to these guidelines must be maintained. A patient must be greater than 8 years old, and children less than 8 years old need to be spinal motion restricted as they cannot consistently verbalize their neck pain. They need to be ANO times 4. They need to know their person, place, the time and event with good short-term memory. Normal neurological exams, motor and sensation are intact in all 4 extremities. No evidence of drug or alcohol use. No evidence or reliable history of a loss of consciousness. No complaints of neck or back pain. No penetrating injury near the midline spine area. And no distracting injuries defined as any significant painful injury. For example, if they have a long bone injury such as their femur or humerus and their tibia, fractures, abdominal pain, chest pain, pelvic fractures, etc. No strong evidence of potential spinal injury and a mechanism of injury, such as a high-speed crash, severe damage, a motor vehicle crash, a diving accident, etc. Even more notes. Always err on the side of overutilization of C-spine restriction if any question exists. Spinal motion restriction is an all or none treatment. Either the patient is supine with cervical collars, backboard, head blocks, straps, or not at all. Applying only a C-collar to a sitting patient is unacceptable. In elderly patients with severe kyphosis, which is a hunchback, remember to immobilize them with extra padding using sheets or pillows under their head. Do not attempt to flatten them into a supine position. For spinal or neurogenic shock, it involves a spinal cord injury where there has been injury to the spinal cord with the resultant loss of sympathetic vascular tone. The patient will have hypotension with warm, pink skin and relative bradycardia at less than 100 beats per minute. It will be assumed that the patient can speak English or that a reliable translator is available on scene to assist with questioning. It is not permissible to clear the C-spine in a patient who cannot communicate effectively with a pre-hospital provider, i.e., a language barrier, deafness, and etc. And with that, guys, that's the end of the trauma section. Now we have the medication list. I am probably not going to do the medication list in this video. This is already taken a lot longer than I thought it would. So what I'm probably going to do, guys, is I'm going to split this up into 2 audios because one is just not enough. Thank you guys for everybody who's watching. If you have listened all the way to the end, you are absolutely insane. And I would love a like, a comment, consider subscribing if you want. And I will see you on the part 2 of this if I have the mental fortitude to verbalize everything. Oh, it is so hard to do this. But thank you guys for watching, and I will see you on the next one. Bye.